So I'd like to talk really quick about bars. There's a place for bars. Not everybody needs them, but there's definitely situations in where bars are gonna help you and your patient. So let's talk about the advantages real quick. Abutment splinting is huge. Studies have shown that if you splint abutment or splint implants together, they're gonna last longer and have better integration. So if you think about all on four, the whole reason they work is from the minute you place them, you splint them together. So using a bar is gonna increase your stability. It helps retain it a little bit more. And then also can accommodate divergent implants. So while we talk about 30 and 40 degrees divergency with stud attachments, bars can handle no matter what the divergency because the bar is gonna line everything up. But when thinking about bars, it all comes down to AP spread. I'm sure most of you are familiar with AP spread, but that's the distance between the most anterior implants, the most posterior implants, the measurement between A and B, that times 1.5 was how far back you can cantilever a bar. So if you look at these implants, if you do stud attachments, they're gonna stop way up here. If you do a bar, you can put them farther back to get more stability. Now, a lot of people don't realize AP spread and cantilever works posteriorly, but it also works anteriorly. So if you think about if you had a bunch of implants placed posterior, the same math works when going forward. This is actually a case, somehow they had 4 locators in here. I don't even know how they got that done. But this case was sent to me and they asked me if it would be good and the patient would benefit from a bar. So I said, well, let's look at the AP spread. It's real simple. You got your anterior implants here. You have your posterior here. That bar is only going to get you back to here. That's not going to do a whole lot of good. I don't know if it's really if it's really worth the patient for the cost of what additional attachment and retention you're going to get. But then again, we see cases like this. Would a bar work on this case? Well, think about it. Here's your anterior. Here's your posterior. You can take that bar all the way back here. So while on the patient's right side, obviously you don't need to take it any farther. On the patient's left side, you can get an attachment or anything farther back than where that last posterior implant's placed. That's actually a good case for a bar. Like I mentioned, implant splinting. I think it's huge. I don't think enough people realize the benefits of splinting everything together. Here's a bar case. If you look at this one, notice the one on the patient's right that's way far off. That one on a stud attachment case, you wouldn't be able to do anything with it. And then on the left side, your last implant is not going to be nearly as far back. But look how many implants there are. 1, 2, 3, 4, 5, 6. You don't need 6. It's too many. With the bar, you're able to line everything up and just put in 3. So you got your tripod of locator attachments. The bar itself is going to help stabilize it, but those attachments are going to help retain it. This is a good case. I mean, not great implant placement, but a good case. So when you have a bar, you're able to do a lot more. The few big ones are, you're able to add a flange, a lip support. So over those fixed cases, you're all on fours, your zirconia full arches, you're not able to bring up any acrylic or anything to help fill the patient's face because a lot of them are losing a lot of that bone because of how long they've been edentulous. Another big thing is it opens the palate. You can do them on stud attachments, but you're going to have a lot more success with an open palate on a bar case. I mean, if you think about how much of a difference in quality of life that is for a patient not having a full palate of acrylic. And then it helps with speech. If you've ever worn a denture or seen a patient that first gets it and not having ability to talk, it's a learning curve. With a bar, you're able to remove that and it's a lot easier for the patient. Like I mentioned, you can fill in that face. So a patient that's been edentulous for a while, their face starts to sink in, you're able to add that acrylic and give them the more youthful appearance out of it. One of the most popular bars is the Hader bar. And most people don't like the Hader bar because they find it hard to work with. but it's coming back in popularity a lot. And I think a lot of it has to do with patients that are in their fixed restoration and they found out that they shouldn't be, so they need to be moved into a removable restoration. Hader bar is a pretty inexpensive way to do it. Plus, it adds very minimal vertical. So you have the bar made, and the whole concept of a bar is it's got a rounded top and then what I call a skirt underneath, and that prevents any rotation. So they come in different nylons, just like all the other attachments. Yellow is your standard. If you find you need more retention, you go to red. If you need light retention, you go to white. The blues came out for those people that still have Hader bars from the 80s that were casted out of gold and are getting thin and thin. Blue might retain it. If not, you probably got to replace that bar. A couple of different housing styles. There's the one with the wings that are thinner. If you don't have a lot of space, but if you do have the space, I always recommend the ones with the kind of crosshairs cut into it. That's going to allow for the acrylic to kind of really adhere to it, more of a mechanical connection. But you'll see the difference in sizes. So while vertically, you're talking what, 0.3 millimeter difference? Other way, you're talking quite a bit of difference. So just depending on the case and how much room you have is how you choose what sort of housing you want. Some common Hader bar problems. It doesn't seat because the soft tissue is pushing that housing up. So you'll see in this picture, soft tissue is either inflamed or it was just done poorly to begin with, and there wasn't that room and that housing cannot engage that bar. Not lining them up when fabricating the denture. So this might be something you talk to the lab about, but lining them up, you got to make sure everything's lined up perfectly on that bar before you make that denture, because then you won't have path of insertion. The whole concept of a Hader bar is those nylon inserts kind of stretch out and go around the bar, and then it's going to snap onto that bar. If not done correctly, what happens is those nylons get pushed up inside rather than go around the bar, and then you'll start seeing those Hader clip bend in. That's a common complaint people have about Hader bars, but it's usually because they're not using the processing spacer. The processing spacer is a simple thing that you're either going to use to pick up chairside or the lab should use that's going to give you the proper area in order to make sure those nylons don't go in, they flex out. So look at this picture. On the right, see that acrylic is between that nylon and that housing. That's preventing that clip from expanding out. It's going to pinch in. The side on the left, that allows that area for it to pinch out, to flex out. So that processing spacer just goes over the bar. You cut it down to the size of the bar, so they come really long and you can cut them to any size you need. This next picture is shown on the model, but you can do it intraorally. You block out everything else. It's all about block out. You don't want any acrylic to touch anything else. Now, a lot of people will do the denture directly onto these processing spacers. You don't want to do that. You got to put the housing on it. So it's processing spacer. Usually use a little adhesive, put the housing on there. Here's a little bit more what it would look like intraorally, where you're blocking out with that permablock all around the area that you're going to put the acrylic. Put the housing on there, more adhesive. Again, you're going to cut out your trough. You're going to have those lingual holes or the buccal holes if you want, and then you'll pick up the cold cure using the chairside acrylic. Then you're going to have the green spacers in there, and it's as simple as popping them out and pushing the new colored inserts in to whatever you wanted to use. While we talk about Hader and they're all the plastic parts, we actually do carry one that's all metal. They're called the Ackerman clips. They're real popular way back in the day, but they're kind of making a comeback. They have a place. So the Ackerman clips, all your retention and all your pressures put on the soft tissue. This is a great option for patients that have really old Hader bars and you're not really sure the quality of bone around those implants. A Hader is going to clip onto that bar, and every time they pull it out, it's going to tug on those implants, and it's just going to cause more damage to them. Ackerman clips will, no pressure on the bar, hardly any pressure on the implants. It's all done on the soft tissue around. Because look at the Hader, it's all done right on that bar. Ackerman clips, they come in two different types, either wider or taller, depending on how much area you're needing to cover. And they use a space maintainer, so that way it doesn't fully engage the bar at all. Great, like I said, great for old bars and compromised implants. And then they look like that when they're attached in. Locator, like I talked about Locator earlier, they are great on bars. Look at this case. Way too many implants and way too different divergency. They are in different angles going every which way. If you had that many locators on a patient, it would be way overkill. 3 in a tripod is where it's at. And if you look at that, you're able to line everything up, and it's added a lot of stability to that patient. So there's a different couple options for locators on bars. People are still casting bars. I see it all the time. There's nothing wrong with that. There's parts that you can cast right to it. There are people that are still laser welding. So if you have an old bar that doesn't have an attachment, you can add an attachment to it. Granted, if you can laser weld to it. But more popular now is the CAD-CAM bars. And those bars will actually tap out a thread, a 2.5 thread, and then these locators just screw right on. It's a really nice option. So if you ever get a lot of wear on those abutments, you can just unscrew it and screw the new one in. This isn't a great example of that. That's a CAD-CAM bar, and it just added the thread. So if you are working with locator over bars, if you notice the picture on the right, the insert, the processing insert is black. When you're working on a bar, you want to use the set where the processing insert is yellow. Sorry to admit this, but for years I didn't know there was a difference. But there actually is. So when you're working on a bar, the yellow doesn't provide any additional room for soft tissue compression. So even though the picture doesn't show it great, that black is actually farther down from the housing than the yellow is. So think about it. When you're doing a locator case over soft tissue, you're going to want some compression, and that's where that area fills in. When you're doing it on top of a bar, no compression needed, so that's why the yellow. You can also do equators on bars. Great way to service something that doesn't have a lot of lingual to buccal space. If you're really compromised on acrylic, really compromised on a tooth being too thin, equator is a great option over locator. You can do clicks, same thing. It's just a ball attachment. Again, it's a 2.25 millimeter ball. It goes into a thread and they just screw right on. If you're into casting or welding on, there are those options. But again, most of them are threaded and it just screws right on. Clicks is a great option. Now this is a new one just for bars. This is called the Sagics. So this is where you're going to add, it's basically a clicks that goes on the side. So very popular on the distal of a ball, distal of a bar, but this way you don't add any additional vertical to this because all of it's done off to the side. Ball sizes for bars are only 2.2. 1.7s are ones that you can get to go on for crown and bridge. So 2.2 for the bar. It comes with a housing that you can embed into the acrylic, or you can also get one that welds to a metal framework. And then again, your same different retention levels. Yellow being the standard, red for stronger, white for weaker. Or you can get creative. Do a CAD-CAM bar. Maybe you don't need it on the distal. This is also on the buccal and the lingual. So depending on the case and where you need to put them, if this was a really compromised vertical clearance patient, great option because you don't add anything to the top. The next one we're going to talk about is the universal plunger lock. This is actually the only attachment I kind of talk about that doesn't go inside of an implant, but it's also the only attachment that prevents lift. So if you think about it, look at this example. You got a bar in the anterior area. Over time, this patient's going to lose posterior bone. And if you had that one Hader clip on the anterior, over time, this thing's going to start to sink down posteriorly. And as the patient bites anteriorly, it's going to lift. It's going to keep bucking up in the posterior, and it's going to make it very difficult. These are basically plunger locks. If you think about, you drill a hole on the side of any bar. You can get them made this way. You can do this with old bars. And this pin will fit inside that hole and prevent that denture from lifting. Every attachment we've talked about, you can pull them out. This is actually a pin that engages the hole that the patient uses a fingernail to disengage. They come in a standard size, and as you're processing or you're adding it to a previous denture, you're going to notice that they're usually pretty long, but they can be cut down to any size. So you cut it down to the size you need, you set it flush with that acrylic or that wax, and then you process. Great for combination cases, ones that deal with locators, Hader bars, all sorts of ones. This is a very interesting case that came into us. It's almost similar to that first AP spread case I showed you, where all the implants were very anterior. Had basically room for one Hader clip. That's going to be a terribly retained denture because it's going to pivot. There's a focal point. But adding these plunger locks is going to prevent the posterior of that to lift. Now, instead of doing a hole, we actually ended up doing a horseshoe. And the reason for that is sometimes that patient wants that compression into that soft tissue to give it more of a natural feel. If you just left the hole, you'd be metal on metal and it'd be very rigid. So they actually went with a horseshoe. Still prevents the lift, but allows for compression. Case turned out beautifully. Again, those are those pins. Those patient actually has to get in there with the fingernail and pop those things out. So when you're working with these type of plunger locks, think about the patient, think about the dexterity, think about, can that patient handle it? It's not easy. You got to really think about the end user. We do a lot of these on combination cases. These are some of the bars we've made over the years. This is that one I was talking about where it's a Hader clip, 2 plunger locks. This is a great case. This thing's not going anywhere. But they don't always have to go in the buckle of the bar. You got a patient that can handle it, you can put them on the lingual. It's a little bit harder to get to, but if they're worried about them seeing that metal circle, switch it on the other side. These are just some of the recent bars that Preet has done. We have partnered with Panthera. They are a bar manufacturing company out of Canada. They do beautiful bars. But with Preet, we do the design. It's our screws, it's our attachments, it's our expertise. They just do the manufacturing for us, and they're just absolutely beautiful. Every time you order from Preet, or if you just wanted one of these cards, like I said, we have these available. These are great, and they come with almost every order. But having this in your office is going to allow you to kind of see what attachment you might be dealing with and what retention level that patient might be at. Dealing with implant cases, I like to talk about the Implant Buddy. This is a catch one, cover all implants. It services, I think, about 97 implants. There's a very few that we don't include on this kit, but they're not very common. So the Implant Buddy is an all one piece. The whole thing is autoclavable. It comes with short and long of drivers for Straumann, Nobel. It's got the 050, the 048, the 035, the angled for our dynamic angled abutments, and it actually comes with slotted, which a lot of people ask me why. And if you ever have a strip screw and you can cut a slot into it, it will save your life. But all these are tapered tips, so it actually holds the screw, so there's less chance of dropping it into a patient's mouth. It comes with a thumb knob, or it does come with a lab use driver. We have the Omega wrench, which is a changeable torque wrench. So getting one of these kits, or I got one with the latch driver. So getting any of these kits will be able to service like 97% of your implant cases. One kit covers it all. Please make sure you use the right driver for the right screw. Those are the sizes I mentioned in the more common systems they work with. Took a lot of calls over the year saying people strip screws because they use an 050 and an 048. And that's a bad day when you can't get that screw out. I run into a lot of people in the lab that talk about I use a universal driver, and there's no such thing. So please make sure the right driver for the right screw. And everything I talked about today, it's all about knowing how to do the case, knowing how to do it right, not spending all your time thinking about how you should have done it, because there's no better feeling than picking up that chairside attachment and it working perfectly. And it engages and the patient's happy. It's a great thing. So that's why I like to call a couple of studs at the bar. Preet does have a prosthetic book. Feel free to reach out to us. It's basically the encyclopedia of everything I talked about, plus so much more. It's a great reference to have. It's got every implant company in there. It's got every attachment, ones I covered, ones I didn't even cover. Just a great reference to have. And just remember, not every case is a simple locator case.